Good morning, everyone. I think everyone's starting to join. So welcome to the Improving Population Health theme meeting. So my name is Ben Barr, I'm a professor in public health. Some of you will probably have met me before, and the lead for the Improving Population Health theme. So hopefully you had a chance to see our video earlier and got a feel for the wide range of projects that we have within the theme. Unfortunately, they were going a bit fast on that video. It was a bit difficult to read some of it, but hopefully you got a feel for it. So in the session today, we're going to focus on self-harm and suicide. This is an area that's been raised by a number of the ARC members as a priority that we should be looking at. And clearly, self-harm and suicide are serious events and preventable tragedies that we can do something about. And in some of these areas, particularly self-harm, there are some worrying trends of increasing numbers of people presenting with self-harm. So the idea of this session really is to hear from some of our members and public advisors about what our priorities should be for looking at public health research and action around preventing self-harm and suicide, looking at some of the models of collaboration that we have in the region for addressing that, and highlighting how we might be able to use some of the sort of infrastructure that we've developed in the ARC to better evaluate what works for preventing self-harm and suicide. So we're going to hear from about one of the sort of models of collaboration from Cheshire and Wirral Partnership. We're going to hear from people from Merseycare about their strategy and how the ARC might be able to support that. And we're going to hear from some of our researchers about infrastructure that we've developed that can help evaluate the effectiveness of interventions. And hopefully at the end we'll have a bit of time to discuss some of your ideas and how we could help best address those priorities in the future. So first up, I'll hand over to Pooja Sani, who's a lecturer in psychology at Liverpool John Moores University, who's going to talk to us briefly about work they've been doing and their model of collaboration with Cheshire and Wirral Partnership. Pooja.
Thank you, Ben, and thanks for inviting us to speak today. So yes, I wanted to discuss an example and showcase maybe a good example of collaborations between NHS trusts and academics and other wider stakeholders as well. So if we could just go to the next slide, please. Initially, I wanted to kind of talk people through the journey that we have with the partner. So in this case, the NHS trust partner comes up with their own service research question that they want answering and that they're kind of looking to commission. So that started off with quite a small project as part of the previous Clark partner priority programme. And then what we have there is the academic institutions becoming involved and helping to facilitate the design of this work. And ensuring that we're using robust research methods. And then the next stage is the formation of the collaborative research team, which I'll talk more about in the next slide when we come to that. And then finally, what we hope is to gain research outputs that are relevant to the trust. So their research outputs aren't necessarily what drives academic research outputs, which is published papers, but they need reports that are more timely, that are written up and returned back to the trust so that they can look at how to implement maybe some changes if required within their own organisations. But what we add, I suppose, as an academic team and other stakeholders is to actually present this work in other arenas as well, in more public-facing presentations and conference presentations as well. And what we hope this leads to finally is changes in service delivery and improvements in patient outcomes. So if we just go to the next slide, I can kind of show you an example of the stakeholder groups that are involved in the work we're doing with Cheshire and Wirral Partnership. So we understand that even though they're focusing more on inpatients and patients within secondary care, for some of the service type of research we're doing, it all connects with community mental health providers, it connects with housing associations as well. And within academia, it's kind of my role to ensure that we have the relevant expertise in the room as well. So, sorry, that might be health economists, statisticians. I've also obviously been involved in the CLARC before. For some people who know, I worked with them previously, and public and patient involvement has always been really important for all of the work. So for myself, I can help the trust navigate how they may involve the public and patient groups that are already embedded within their trust, and also wider partners, and how we might advertise that. So what we might do is help them to put adverts together that they could then send out to their public and patient groups that are already available. Also, I think a really important aspect is their clinical leads and medical directors and commissioners, the people who are going to make the decisions within their organisations once we present the findings of our work to them. And what we found with the projects we've worked on to date is those implementations and changes have actually been much quicker because they've been involved in the conversations from the outset, and they, some of them are part of our steering groups and involved in that sense. The final group that I think is really important is the trust's own staff. So their service improvement managers, their trust data analysts, so the people who are internal and understand their data and share it with us. And we've had to obviously get all of your relevant ethics requirements for these projects, but those people in the trust, I don't think we could have done a lot of the data sharing without their involvement as well. So it's a really wide group of involvement that we've required. If we just go to the final slide for my section, please. So I wanted to just showcase here, I know it's a little bit busy, but if we look at the bottom section where it's red with the CLARC Partner Priority Programme, that's where our first collaborative project started. I was their facilitator, academic facilitator within the project. And from there, we worked on how we might form a collaborative group. And this has since led to changes in service delivery for assessing risk. We've also had a publication in Frontiers in Psychiatry. They've published this work at numerous conferences. And it's really led to internal conversations within the organisation about how they're assessing risk when, and how kind of staff are influenced with their decision making when admitting patients to inpatient units. This has then led to a second kind of tier of project, which is being commissioned for myself to lead at Liverpool John Moores University. And what my role has been is to kind of set out how much it would cost to get research assistants or research associates to complete the work required for the trust to answer their new research questions. And together we've worked out what budget is available and what needs to be done. And already this work is leading to dissemination in international conferences, and a protocol has been submitted. We've got all the required ethical approvals from the NHS and we've had to get wider ethical approvals for this study. But with our academic expertise, we've been able to help the trust do this. The final bit we want to talk about is how I'm now getting embedded within the trust to work with them more to help mentor and facilitate their own clinical leads to start leading in NHS applications, not NHS, they're NHR applications for funding grants, so that we can start getting some external funding as well. So I hope this showcases a bit of what we're doing, and it was a real whistle-stop tour there for you all.
Thanks, Pooja. I think it's a really, really interesting insight into something that I think lots of us are grappling with, is how to kind of reduce the gap between research and practice, and get that turnaround much faster, so that it actually, that research gets into changing practice as new evidence arises. And similar things we've been working on with Merseycare and across the integrated care system of Cheshire and Merseyside. So I should have said before, if you have any questions that you want to put in the chat, we can collate them at the end for discussion as well. So please feel free to add things to the chat as you think of them. So now we'll move on to hear from Claire Iveson and Wes Baker at Merseycare, and what they're looking at in terms of using data to identify priorities and better develop responses. So I'll hand over to you. Claire, are you starting, or is it Wes? I'm not sure.
Yeah, I'll start. Thanks, Ben. So yeah, just to say, I'm a consultant clinical psychologist, and my role is the clinical and strategic lead for Zero Suicide in Merseycare. I'm going to start again a little bit of a whistle-stop tour with some data for context. I'm just mindful when I'm sharing data that, these are sad lives lost. So when I'm sharing it respectfully. I'm also going to think with you about our strategy, tell you a bit about that, and then with the help of Wes, he's going to talk about our new projects around the dashboard. Next slide, please. Okay, so this slide shows the last 4 years of the number of deaths by suicide of service users having contact with our trust within the last 12 months. And you'll see there that it includes 2020-21 pandemic time. And you'll see that there's a sustained increase between May and August in 2020. So I guess that, just to give you a feel for the numbers, there were actually 36 sad deaths by suicide in that 4-month period, compared to 2019, where we saw 38. So clearly we were, very worried about this. The small chart down towards the bottom of the slide basically just highlights where our hotspot areas are. So community services, which are things like urgent care, community mental health teams, these are the areas where suicide actually occurs. Next slide, please. So just to say a little bit more about COVID-19, unusual circumstances nationally and internationally, and the NCI report published in November outlined that there was no significant increase actually in suicide seen prior to and post initial lockdown. It was actually quite controversial. But what they did say is that there are some caveats in that, and that's with regards to the impact in more economically deprived areas. So Liverpool was one of those areas. And if you just go to the next slide, please. What you can see there is in 2020, there was an increase of 15 and a smaller increase in Cheshire East. So we were kind of duly concerned really, and really needed to think carefully our emerging strategy. Do we need to make any changes, and what can we do going forward, reaching out to our population? Next slide, please. So what have we been doing about this, and I guess what's needed from clinical services and the external wider system? So we revised our strategy in 2019, and we learnt an awful lot from our first strategy, which started in 2016 when we first launched the idea of working towards zero suicide. And of course, suicide research has advanced, clinical practice and knowledge has advanced about effective interventions. And all of this has been embedded within our current strategy. And this strategy is both internally focused, so how can we change our systems and processes to make them more reliable? How can we ensure that we both assess, intervene and monitor rather than, assessing and triaging? but also how can we reach our broader population and our community in which we're designed to provide help and care and treatment for. So in addition, and I guess this is what sparked the idea around this new project, we have been learning from deaths. We continually learn, always through our reviews. But with the help of Holmusk, which is a digital solutions company, last year, what we did was we asked them to look at 145 sad deaths by suicide, looking at much larger numbers with new technology. And this was really insightful, and we found a number of risk factors that actually we perhaps wouldn't have come across if we were doing traditional reviews. And what that did is it helped us see that our strategies meeting actually what these insights were telling us. So that was the beginning of sparking the idea, if we can do this internally, what could we do and what's possible with much larger data sets within population health? So that formed part of our action plan. Next slide, please. So this is just a snapshot of our action plan. So what we want to do internally is manage transitions within our services and out. We know that these are risky. Be better at delivering suicide-specific brief interventions, reduce variation, train the workforce. And here is our the basis for our new project, which is about how do we really understand our population? How do we prevent suicide attempts? And how do we prevent it and intervene in real time? Next slide, please. This is, again, once we have this intelligence that we're trying to develop with the dashboard, this is where we want to share it and what we want to do. And I'm just going to hand over to Wes just to show a snapshot of the dashboard and talk us through it.
Yeah, can I just, if you can stop sharing, I'll share my screen. Thank you. Hopefully that's come through. So this is the dashboard that we've created. It's based on the longitudinal health and care record. So this is in Cypher, which is Combined Intelligence for Population Health Action. It's a linked data set with acute mental health, primary care, community, and social care data sets linked to the NHS number. So it allows us to look at multi-dimension aspects of people rather than just looking at the community or mental health data and not looking at the whole data lake of that individual and their pathway. So this is just, we're just looking at, I've just filtered for the whole of Cheshire Merseyside, and I'm looking at the suicide cohort. So this is anyone who has a high risk of identified as suicide by their GP. And this basically tells you what's the long-term condition that's been identified up here, seeing depression, obesity from the long-term conditions register for those people in that suicide cohort. We also have another health diagnostic markers from the Johns Hopkins ACG tool, which just gives a bit more information and intelligence that goes a bit further than the GP long-term conditions register. For example, it gives you things like schizophrenia and affective psychosis coding, which you sometimes don't get, so it just enriches it. And then we have a table here which around how many of them have 1, 2, 3, 4 long-term conditions. And this is still, we're still developing this dashboard, so there's still a lot of work that needs to go about to complete this. But we're hoping this dashboard could then allow us to start to get into more sophisticated data science work, where we start to be able to risk stratify those groups of patients and actually intervene earlier. In addition to this, we're able to share this with other Cypher programs, so we can switch this on in any other dashboard in any other Cypher program in any ICS that's actually, say for example, Lancashire are getting this set up at the moment. Once this is complete, we can action this and they can have this dashboard for their population as well. If I just stop sharing now and hand you back.
Okay, and just the last slide, please, Dan. The last one, there should be one. Thank you. Yes, so Wes summed that up really, and I guess from a clinical and intervention point of view, and to support my role in designing the strategy for all the different services within Merseycare with regards to suicide prevention, we hope that this dashboard is going to allow us to learn, respond and prevent ahead of tragedy with risk intelligence, and ensure what we design is bespoke for our communities and align this broader and larger health data with our resources, so we can think about how we deploy our workforce and where we deploy it. And again, we can respond with advanced information and action when people present in crisis. Thank you.
Thank you, Claire. Sorry, trying to unmute. Couldn't find the button. Thank you. That was really interesting, and it's something that in the Improving Population Health theme we're looking at, working closely with Merseycare and across Cheshire and Merseyside as to how we can better use some of these data to identify who's at risk early and better respond and prevent. So one of the things we're going to look at now, sort of finally, is how we've used some of these data, sort of data assets, both through CIPHER and through the place-based longitudinal data resource, and how we can use that to help evaluate some of these interventions to understand what works best. And I'll hand over to Kostas. I think you're going to take us through.
Hello, everyone. Yes, I'm Kostas Daras, and in the next few slides, I would like to talk about the place-based longitudinal data resource and how this data infrastructure supports the evaluation of the effectiveness of interventions in Northwest Coast. Next slide, please. So the PLDR is a data collection of about 163 longitudinal indicators, of which 31 are safeguarded indicators and 132 open indicators. To create these indicators, we have collected information and data from many organizations like NHS Digital, Local Government Finance, Department of Work and Pensions, Census, DEFRA, Police, ONS, and so on. And from the 132 open indicators, 93 of them are publicly available via our PLDR website, and you can find this data at the link at pldr.org. The public can, for each of these indicators, can find, of course, the data set, but also we provide documentation where we're explaining how we collect the data, the sources of the data, and the methodology we use to create the indicators. So this resource is updated regularly, and also we are planning to upload more indicators in the near future. Next slide, please. So these PLDR indicators, we've used them for our projects to evaluate the effectiveness of interventions, as I mentioned earlier. And we mainly use a quasi-experimental method known as difference in differences. Excuse me. As you can see in the graph, the difference in difference method captures the significant differences in outcomes across the intervention and control groups, which occur between pre-intervention and post-intervention periods. This way, we are able to measure the effect of the intervention. And below, I've just mentioning a few for our projects that use this approach. And the first one is the NOSLI chronic obstructive pulmonary disease service evaluation. Also the communities in control project where we investigate the impact of providing the big local program on mental health outcomes. The community wealth initiative in Preston, where we estimate the impact of this initiative on the primary outcome of mental health, and more specific, we use here the small area mental health index, where we created in PLDR, and it's public on our website. And the final one is the self-harm, which is on impact of the HOPE initiative on hospital admissions for self-harm across Liverpool. I'm going to stop here, and I'm happy to answer any of questions you might have in the discussions, and I'm going to hand over to Roberta or Ben. Thank you.
Okay, I take over. Can you please change the slide then? So we are talking here, Kostas presented a data resource that we have used, and our data resource that we have used to provide help to the NHS and our stakeholders in the service is CIPHER. Wes has already described, CIPHER is a data resource that contains information about each single person in Cheshire and Merseyside. We have used a portion of this data, which contains information about all the people that are registered with a GP in Liverpool, that's about 500,000 people, to develop a tool which is called RISE. And next slide, please, Dan. So the clinical clinicians in Liverpool, that is the people that make decisions of which services to fund in the NHS, have a lot of rich data, and they asked us to develop a way in which they could more easily ask questions of this data. So in taking questions about which interventions to fund or how to change them, these decision makers needed to have evidence about which intervention or service is working in the way they thought it should work. So questions that the decision maker would ask would be something like, are we achieving the outcomes that we wanted to achieve? For example, are people staying in hospital no longer than they needed to? Are people going to screenings when they are prompted? Or are we reaching the people that we wanted to use the services? And there was no easy way to answer these questions from a huge pool of data that are recorded just for administrative reasons. And that's what the NHS starts with. So we offer to design a tool which would simplify answering these questions. And since people talk about smart solutions, here is the concept of what we devised, symbolized by a small smart car with a disclaimer that our small and cutely round vehicles are available. So specifically, we concentrated on developing 3 parts of the car. One is a better connection to the fuel and a better distribution of the fuel, and the fuel here is the data. A second part where we concentrate is an upgrade to the engine. We gave an analytical engine some prompt, a way to manipulate the data in such a way to propel the car more into evidence from just raw data. And we offered to have an addition to the dashboard with some new indicators to see how fast they are going in terms of implementation of interventions, if there are some problems in some part of the services, for example, sort of if you have low pressure of the tires or low pressure is sort of like in one part of the service. Next slide, please. And so we developed a tool which has these 3 components in connection to what I said before. There is a database interface, a connection from the data from different sources. It's all put together in one flow, and then this flow is tidily organized and labeled, so it's ready to be interrogated. Then we built, for the analytical engine, we built a way in which we can compare likes for likes, because it's not easy to see if interventions are effective if we are not comparing people that have similar problems and needs. And then we also used these comparison groups to do a difference analysis, which Kostas has already explained. And then from this analytical engine, we generated reports that show what happened to the outcomes that are relevant to a specific intervention in the period before and after we started the intervention or changed the intervention. And we can also see how much things have changed and how much time it took for these things to change. So we used this data resource, CIPHER, and this method, which we called RISE, to evaluate interventions like the COVID-19 vaccine bus in Liverpool, find out what happened to shielding people in Liverpool. We tried to find out what happened to the trend in antidepressant prescriptions during the first months of COVID. We evaluated integrated care teams working in the community and joining up many different professionals. And now in the pipeline, we have evaluating the effects of COVID on mental health for children and young people. We have talked about this in one of our ARCFEST. We also evaluating social care services targeted at specific groups of people, for example, homeless people. We are planning to evaluate services for expecting and expecting mothers and mothers that have young children that have just given birth and find themselves in experiences of hardship in terms of financial hardship or isolation, social hardship. And hopefully, sort of like we will also devise some way of evaluating interventions related to self-harm and suicide prevention. And thank you very much. This concludes this part.
Thank you, Roberta. That's great. So we have these two kind of data resources. One is at a place-based level that Kostas has outlined, and one is more following individuals that Roberta has outlined, and both of those provide very flexible tools where we can quickly evaluate what's working and what isn't. But importantly, there's another step to that, which Claire and Wes have highlighted, is how we use those data to identify needs and where the risks are, and how we can target those risks earlier, so that we can prevent these adverse outcomes. So one of the things that we really, we're really helpful to hear from you. If you go to the next slide, and it's really, we've got 10 minutes before the end, or slightly less now. Is to really understand if there are any thoughts from yourselves as to where we should be focusing our efforts to reduce self-harm and suicide, particularly in terms of prevention, and how we should better collaborate, and what collaborations would be more effective in supporting that, and particularly if there are promising approaches out there that we could be evaluating and spreading to other parts of the region. That would be great to know about and to work with you on. So any questions? I know Emma, you put a comment in the chat. Do you want to ask about that?
Yes, I can do. The questions in the chat effectively. I don't have, off the top of my head, I don't have specific examples of interventions, but I was interested, I think, in Pooja's presentation. There was a discussion around kind of collaborations with housing associations or providers. So it was a really kind of interesting presentation. I thought lots that's kind of going on already, and I was just interested to know, are there already work that's happening at that sort of community level, particularly thinking about prevention and looking at protective and risk factors for suicide and self-harm, or is there opportunity to sort of explore and develop that a bit further in terms of thinking about future intervention, development and research?
Yes, I think it's really important that some of these things are focused on health services, but obviously we can potentially have much bigger impact looking at wider prevention programs. Pooja, did you want to say anything about?
Yeah, just with Cheshire Rural Partnership specifically, that's an area we're looking at doing more work in the very near future. But I'm also involved in work where we are evaluating community-based models. One being James's Place in Liverpool, and the other one where we've implemented a self-harm intervention within community settings that is an adapted one that's already in Merseycare and hospital settings. So we are doing more in the community, but I think it's much further behind than the work that's been going on in hospitals.
I wonder whether you might.
Yeah, I was just going to add to that with regards to CHAMPS and the No More Suicide Board. There's lots of initiatives going on there, particularly men's mental health, suicide prevention for men, sports, everything in the community, and the development of these kind of hubs where people can just go and they're in a place where traditionally it's been a really deprived area and lots of social difficulty, turning it into a kind of community hub where people can just go and I know there's an evaluation plan going on there too. So I think that the CHAMPS No More Suicide is very much linked into some of these community developments.
I was wondering if you know, in terms of those evaluations or the evidence base around some of those things, is there more that could be done, kind of with the kind of things that we're talking about here? Do you think, or how might we, within the work that Wes and colleagues are doing with Mosicare, we might be able to evaluate some of those programs?
Mm-hmm. Mm-hmm. Yeah, absolutely. Yeah.
Because I mean, one of the other sort of partners that has been in contact with us is Life Rooms in Liverpool, which I suppose is a kind of broader community approach. But often those more sort of, well, often it's easier to evaluate some of the health service based interventions and harder to evaluate some of the sort of broader community interventions, which means the evidence tends to stack up in one place where it's not necessarily where things are most effective. So I guess it is, well, one of the questions is how can we best develop more robust evidence around those broader community programs?
Yeah. I think absolutely. I mean, even in I was really encouraged to hear Pooja's talk, actually, because there is a myriad of things that could be evaluated linked to the strategy. One such as, like, when people attend urgent care, they have a flashcard safety plan, and then we follow that up with a compassionate text. And this is a new initiative that we're trying to kind of spread out across our footprint. Anyone who goes to A&E gets followed up where there's really strong evidence. So there's just an example of a small project that potentially has got a lot of potential. So that's kind of within the NHS, and absolutely Life Rooms and recovery orientated community services. Lots.
Yeah, I think there is. Pamela, you've put a question in the chat about research focusing on how to keep people well. Did you want to just expand on that at all? Are you there?
Oh, I'm trying to get my video on as well.
That's okay. That's all right.
But that doesn't seem to be working. Yeah, I'm very much population health focused and very interested in health creation, and I'm working at Liverpool John Moores but doing my PhD with the University of Manchester, and I see a different approach across the two areas. In terms of Liverpool's focus seems to be on conditions like drug abuse and suicide and mental health, and there seems to be a much more community focused reach from Greater Manchester in terms of the Wigan deal and things like this. And I'm just thinking how we can build on that capacity within my area with that health creation focus.
Yeah, so the work in Wigan, what are the kind of elements of that? Is that?
It's very much co-creation, so a co-creation in terms of how do we understand what makes people feel well, and when they asked the local population, it wasn't even services, it was things like litter and potholes and how that actually makes people feel about their environment, which then impacts everything that how they feel about their home, how they feel about personal safety. And it's building that capacity within what I see as that sort of Liverpool and beyond. How do we build on that knowledge to support our communities? Because I see that we've got huge resources within universities, especially in terms of students. And how could we use our students to actually make those connections?
Yeah, no, I think that's really interesting and links to some of the work that the EPIC theme is doing as well, and some similar projects. For example, what we're doing with Preston, where we're looking kind of much more broadly at sort of economic and workplace developments. I'm just aware that we're probably going to be cut out of our session at the end any minute now, and moving into the onto the next thing on the agenda. So I'd just like to thank everyone for joining us, and I hopefully you've got something useful out of that, and I really encourage you to get in touch with us about the projects and things that you've discussed, and we can look at how we then take that forward and support that through the ARC. So I'd like to say thank you for everyone for coming, and we'll see you again at the next ARCFEST.